Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and Med Talks, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra. Today's topic is a very interesting topic: diabetes and exocrine pancreas. Diabetes Essential is brought to you by your zero calorie electrolyte drink in Azal Zero. Now, before moving forward, I would like to announce the last week quiz winners: Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Prachita Srivastava from Thane, Dr. Gangadhar Rath from Bhubaneswar, Dr. Kaval Saluja from Mumbai, Dr. Bharat Praveen Mitakota from Surat, Dr. Surjit Kalsi from Noida, Dr. Ravi Bhatt from Sirsi, Dr. Shashi Khare from Bhopal, Dr. Ashwini Kumar from Kanpur, Dr. Rakesh Mohan from Ghaziabad, Dr. Nariman from Mumbai, Dr. Satish Kumar Jain from Bangalore, Dr. Rajiv Handa from Delhi, Dr. Ashwani Malhotra from Delhi, Dr. Girish Jesota from Mumbai, and Dr. Sanjeev Free from Hoshiarpur, Punjab. Thank you all the doctors to take part in our quiz. Now, to enlighten us regarding today's topic, I would like to welcome our host, Dr. Sanjay Kalra, President, South Asian Federation of Endocrine Society, Chairperson, Education Working Group of International Society of Endocrinology, and President, Indian Professional Association for Transgender Health. Over to you, sir.
Thank you, Ankur, and good evening, everybody. Warm welcome. Ankur, thanks for this introduction, which you always give. It just so happens that now on the 15th of December, I will be stepping down as president of SAFIS and also stepping down as president of IPATH. So that makes me a very free bird and a very happy bird also. So
Yes, sir.
it's like if I were to speak in Hindi, Azad Panchi ban jaunga and I can fly wherever I want. But wherever I fly, wherever I go, diabetes essentials will be part and parcel of my life, and we'll continue this journey together. And warm welcome, Dr. Siddharth. It's always good to have you on the show. Today, we'll talk about a different type of diabetes. And our topic for these 2 months has been glucocrinology. We've been speaking about various various connections of the endocrine system with diabetes. So we talked about pituitary and diabetes, thyroid and diabetes, adrenal and diabetes. Today we'll talk about the exocrine pancreas and diabetes. Now, why is this important? First of all, patients with type 1 and type 2 diabetes have got endocrine pancreatic disease. Endocrine pancreatic disease. Theoretically, the exocrine function is supposed to be unaltered or unharmed. However, there are studies which show that around 10 to 15% of type 1 diabetes and up to 33% of type 2 diabetes patients have got exocrine pancreatic deficiency. Number two, there is something known as pancreatic diabetes. It's also called type 3C. Pancreatic diabetes occurs because of inflammation or destruction or surgery of the pancreatic tissue. And when this occurs, both the endocrine and the exocrine functions are deranged. So that's why it's important to know about the condition. It helps you diagnose properly and it helps you treat properly. So, two reasons. First of all, type 1 and type 2 diabetes may be associated with exocrine deficiency. And number two, pancreatic diabetes separately can cause endo and exocrine deficiency together. The etiology is usually inflammation, pancreatitis. Pancreatitis can be secondary to gallbladder disease, it can be secondary to alcohol, it can be idiopathic, it can occur because of various drugs like oral contraceptives. Apart from inflammation, there may be injury. You may have a trauma to the pancreas. Another kind of injury is iatrogenic, where there's a pancreatectomy. The pancreatectomy may be again following trauma. It may have to be done because of severe pain because of pancreatic stones, and it may have to be done because of neoplasia. So, I for inflammation, I for injury, I for iatrogenic, and I for invasion. Invasive is pancreatic neoplasia. These etiologies are important because you have to fix the etiology if you want to manage the patient. Sometimes, of course, we can't fix the etiology, like there's a pancreatectomy. Patient has come to you after a Whipple surgery. So you have to live with that. But you don't have to suffer from that. Actually, in Buddhism, there is this concept that pain is inevitable, but suffering is optional. So our patient should not suffer. And these patients with the diabetes of exocrine pancreas have got additional symptoms related to pancreatic disease, which you have to manage in a symptomatic way. Now, one difference that occurs in pathogenesis of type 1 diabetes versus uh, pancreatic diabetes is, in type 1 diabetes, the beta cell function is impaired, so you have low insulin. In pancreatic diabetes, however, alpha cell function is also impaired, so you have low glucagon. If there is low glucagon, there will be one less counter-regulatory hormone for hypoglycemia. So a person with pancreatic diabetes is more prone to hypoglycemia as compared to a person with type 1 diabetes. People with type 1 diabetes will have more of hypoglycemia unawareness, but people with pancreatic diabetes will develop hypoglycemia much faster. It will be symptomatic. Second is because of the inflammation of the entire pancreatic tissue, there is exocrine insufficiency, which leads to malabsorption of nutrients, both micro and macronutrients. When you have malabsorption of nutrients, you will obviously get malnutrition. So people with pancreatic diabetes have got malnutrition. They may present with steatoria and they may present with diarrhea. So steatoria, diarrhea, and malabsorption. Apart from this, pain is a very characteristic symptom of pancreatitis. So people with acute pancreatitis will have acute pain. Those with chronic pancreatitis will have repeated episodes of pain. And the nutritional deficiencies then lead to other symptoms, other signs. You may, for example, get a nutritional neuropathy, a metabolic neuropathy. So patient may present with overlay of diabetic neuropathy and also vitamin neuropathy. People with pancreatic diabetes will have protein deficiency. So they might end up with edema, a very subtle kind of edema over the shins. You can't find the etiology. Kidney is normal, thyroid is normal, and it's actually because of protein deficiency. We call this subclinical kwashiorkor. It's not that it's subclinical, you can see the edema, but subclinical kwashiorkor tells us that it's just a mild type of kwashiorkor and we should take it seriously. Just to repeat, in all types of diabetes, insulin comes down. Even in type 2 diabetes, after the initial hyperinsulinemia, it comes down. In type 2 diabetes and type 1 diabetes, glucagon secretion increases. But in pancreatic diabetes, glucagon secretion goes down. In pancreatic diabetes, somatostatin increases and pancreatic peptide secretion comes down. Now, how do we identify? Uh, Basically, diagnostic criteria are there, but not very strictly followed. You go clinically. So you take a history, you get a history of diabetes, you get a history of being less prone to ketoacidosis. Ketonuria will occur, ketosis will occur, but ketoacidosis is rare. Secondly, there will be GI symptoms, pain, malabsorption. GI symptoms will be there. When you do the imaging on X-ray or on ultrasound, you will find pancreatic stones. You will find you will find evidence of pancreatitis. You may find a shrunken pancreas. You can find pancreatic stones. There are potential alterations in incretin secretion as well, but these are not used for diagnosis. And like we said, there will be nutrient deficiency, micro as well as macronutrient deficiency, but these are also not used for diagnosis. They help us support the diagnosis. Even otherwise, in routine practice, we should be supplementing vitamin D for everyone. For people with the pancreatitis and impaired absorption, the other fat soluble vitamins like A and E, especially E, may have to be supplemented. What is the aim of treatment? It's exactly the same as it is in type 1 and type 2 diabetes, but a little bit extra. So we want to normalize the HbA1c, we want to reduce long-term risk, and also we want to reduce the risk of pancreatic cancer. That is one extra thing. Another thing is that we have to minimize pain. Pain is something important that they come with. We have to help in weight gain. Now, in type 2 diabetes, when you read the guidelines, they always speak of weight loss, weight loss, weight loss. Actually, the correct term should be weight optimization. In these patients, when you want to optimize the weight, you actually have to increase it. So if you improve the absorption, weight will go up automatically. So we want to correct the symptoms like pain, weight loss, steatorrhea or diarrhea. We also, in the long run, want to prevent the development of diabetic complications and also CA pancreas. What is the special advice that we give? Now, first of all, lifestyle advice: small, frequent meals. Small, frequent meals. Do not exercise immediately after meals. Secondly, pancreatic enzyme replacement therapy. Now, many brands are there. Pancreatic enzyme replacement therapy is very important. In this, we give pancreatin. So, there are some drugs which have pancreatin and dimethicone. There are others which have only pancreatin. Dimethicone has no added advantage. So, a plain pancreatin replacement is indicated. Choose a good brand. Choose a brand with microsphere technology, because when there is um, obstruction or spasm of the pylorus, only 2 millimeter or below 2 millimeter granules or spherules can cross the pylorus. So you want microsphere technology where the pancreatin spheres are 2 millimeter or less in size. One good brand which I use is Creon, and you can use in a dose of 10,000 or 25,000 units with meals. Sometimes you have to give more. Very rarely people will take 35,000, 10 plus 25. Even more rarely 50,000, 25, uh, 2 taps, 3 times a day. And sometimes you will find gastroenterologists prescribing 10,000 maybe before a meal and 25,000 during the meal to help in symptom relief. Now, why is pancreatin given actually? It is given because it has a negative feedback mechanism. When you give pancreatin from outside, exogenous pancreatin, that reduces the secretion of pancreatin from the pancreas. When it reduces the secretion of pancreatin from the pancreas is able to relax. And when the pancreas relaxes, it produces less secretions, there is less pain. So, pancreatin replacement, pancreatic enzyme replacement therapy, the primary indication is painful pancreatitis or painful pancreatic diabetes. It helps reduce pain. You have to give it with each meal. The second indication is steatorrhea. So when patients have steatorrhea or malabsorption occurs because there is not enough pancreatic enzyme for absorption. So if you replace from outside, you can reduce steatorrhea as well. If your patient is asymptomatic, patient has no malabsorption symptoms or steatorrhea, patient has no pain, you can reduce or taper off or stop pancreatin therapy. It is a bit expensive, but keep on giving it. There will be some patients who will say, I've taken pancreatin for the last 2 or 3 years. Now I don't need it anymore. This is because of burnout phenomenon. What happens is, see, why we were giving it? So that we could reduce the endogenous secretion of pancreatin. This will help us reduce the endogenous secretion of pancreatic juice, which will reduce pain. If the pancreas burns out after repeated episodes of pancreatitis, there is nothing left in the pancreas. It has scarred. There is scarring of the pancreas. There is scarring of the nerve endings around the pancreas. Then there will be no pain. And that is why then pancreatic enzyme replacement may not be needed in patients with long-standing pancreatic diabetes. So this is something very important. For the average patient, I would begin maybe, apart from the insulin and other drugs, I would begin maybe Creon 10,000 unit 3 times a day before meals and see what happens. Whenever you are giving pancreatic enzyme replacement, do remember to add a PPI, proton pump inhibitor, whatever you feel like, pantoprazole, rabeprazole, omeprazole. If your patient has heart disease as well and is on clopidogrel, then pantoprazole is safer. There are less chances of drug-drug interactions. Now, how do you manage diabetes? In patients with pancreatic diabetes, gliptins are contraindicated. Do not give gliptins. GLP-1 receptor agonists are contraindicated. Do not give GLP-1 RA. Pioglitazone you may give if you want weight gain, but usually we avoid. If your patient is eating well and absorbing well, you can give metformin. If however your patient is malnourished because of poor intake or poor absorption, then metformin is not a good idea at all. Metformin is a calorie restriction mimetic. It acts upon the mitochondria, increases AMP kinase. It acts as a mimic of calorie restriction. If your patient is already calorie restricted because of less intake or less absorption, it makes no sense to add the burden of metformin. However, insulin is the drug of choice, and in people with pancreatic diabetes, we need small, frequent doses of insulin. Small doses because you want to avoid hypoglycemia because the alpha cell cannot secrete glucagon. Frequent doses because you want one for each meal, and prefer analogs. When you give an analog, what happens is that the safety level goes up. The duration of action is slightly, and there is less risk of hypoglycemia. You can use rapid acting analogs. The ones that are available in India are Lispro, Aspart, and Glulicine. Use any of them. But now we have ultra rapid acting analogs. The ultra rapid acting analogs are early URLI, that is ultra rapid acting Lispro, and also 5-ASP, fast acting Aspart. Early and 5-ASP can be given anytime from 5 minutes before a meal to 10 to 15 minutes after a meal. So patient can take the meal, see how hungry he or she is feeling, take the meal, then see how well it's digested. And even after 5 or 10 minutes, they can choose their dose. They can count and they can take 4 or 5 or 6 or 3 units, whatever they feel like. There are some people with pancreatic diabetes who will have brittle diabetes, and they will come back and say, sir, when I take 4 units, then I have hyperglycemia. When I take 5 units, I go into hypoglycemia. So you can give 4.5. So there is a junior quick pen which gives Lispro in half unit increments. So you can take half, 1.5, 2.5 units. It is used in pediatric diabetes, in geriatric diabetes, and in pancreatic diabetes. So, what we said was small, frequent doses of analog insulin. That is the best treatment. In analogs, you can choose rapid acting, Lispro, Aspart, or Glulicine. But better would be ultra rapid acting, early, that is URLI, or 5-ASP. And if there is brittle diabetes and if you feel the need, you can also order a junior quick pen, which will give Lispro in half unit increments. This will control the postprandial glucose, but for fasting glucose, you will need basal analog. And you can choose a long-acting analog like Glargine or Detamir, or you can choose an ultra-long-acting analog like Glargine U100 or uh, Degludec. All these are fine, and whatever you feel comfortable with in practice, you can use. Be aware of cost as well. Pancreatitis is an expensive disease because patients have to get admitted in between. And pancreatic diabetes, however, is less expensive. Still, you have to give pancreatic enzyme replacement and analog insulin to your patient. If your patient cannot afford it all, then a PPI is must, pancreatic enzyme replacement if there is pain or steatoria, and you can use human insulin. But be aware that you will have to monitor more frequently to avoid hypo. Let's come to our questions for today, and we go back to physiology. So, which of these following of the following hormones is produced by the alpha cell? What does the alpha cell produce? Is it insulin, glucagon, somatostatin, or amylin? And this hormone raises blood glucose. Which one is it? Coming from the alpha cell, raising glucose. Is it A for insulin, B for glucagon, C for somatostatin, and D for amylin? And we then go to another physiology question. What is the primary function of the exocrine pancreas? The exocrine pancreas. What does it do? Does it A, produce insulin, B, secrete glucagon, C, secrete digestive enzymes, help in digestion, and D, help in regulating plasma glucose? So another physiology question. What does the exocrine pancreas do? A, give us insulin. B, give us glucagon. C, help in secreting digestive enzymes. And D, help in regulating glucose. With this, we come to the end of today's talk, but let's look at our questions now. And lots of questions. Warm welcome to Fatima ji, who is doing graduation in human nutrition and dietetics. And she's from Pakistan. So warm welcome, Bete. And we are very happy to have you with us. In pancreatic diabetes, it's very important to have a good nutritionist. Small, frequent meals. Sometimes patients are not able to absorb meals, so you tell them to take high fiber diet. Sometimes they're not able to. So you tell them simple ways of cooking. Now, see, Fatima, nutrition means we tell our patient take 40 grams of protein and take maybe 2000 calories and 500 milligrams of calcium. This is very abstract. Patient will not be able to understand. That is why we need a qualified nutritionist or dietitian to change it to diet. So then you will say to your patient, and you might wish to speak in Urdu or Hindi, कि आप दो चपाती खाएं और साथ में एक कटोरी सब्जी खाएं, एक कटोरी दाल खाएं और एक कटोरी मीट खाएं. Now patient understands this. But above this, there is another level that is called culinary medicine. Culinary, culinary medicine. Here we teach the patient how to cook. Let's take an example. You tell your patient, take chapati, but don't apply ghee on it, don't apply butter. Anybody from North India, anybody from Punjab will say, I cannot eat. So you have to tell them how to cook chapati. So you say, when you are making the dough, जब आप आटा गूंद रहे हैं तो आप आटे में दूध या दही डाल दें थोड़ी सी. आप पानी के साथ आटा गूंदते हैं, उसमें 10 या 20 पैसे दूध या दही डाल दें और बिल्कुल मुलायम सा आटा बनेगा, मुलायम सी रोटी बनेगी. यू विल हैव वेरी सॉफ्ट dough and you will have a very soft chapati made out of that. Supposing your patient is taking idli. Now, idli contains rice, so it will have a glycemic load, it will have a glycemic index. So then you tell them, when you are making the idli, you add a little bit of chopped vegetables to it, or you add a little bit of chopped dal to it inside. So when you add those vegetables, the glycemic index will come down. This is called culinary medicine. Another nice word to know, and once again, welcome to Dr. Siddharth, and also to Vinayak Sharma ji and Dharmender Javan ji, and thanks Sanjay Marathe for your kind words. Another nice word to know is aristology. अब मेरे को अच्छा पड़ा लगता है ये चीजें करना, because I love learning new words and I love sharing them with everybody. So aristocracy. Aristocracy means show off karna, like you are superior, you are from the upper class. But aristology means the science and art of dining, of eating food. तो इसमें चार हिस्से होते हैं. How do you procure food? How do you prepare food? How do you process it? How do you present it? How do you plate it for the patient? And that is what we all learn, and that's what Fatma is learning in her second year. Now, aristology means the science and art of dining. And if you're able to sort of, as a dietologist, you're able to understand the nitty gritty of food, go into the kitchen, learn how to cook. Even you don't cook yourself, look at all the steps, see how you can change things. And we come now to Dhavan Sahab's question. This will help you manage diabetes. So we have to learn diabetology, endocrinology, and aristology together. And warm welcome, Dr. Yogesh Shuklenchwar. We were just speaking about food because it's dinner time. Now, and Dharmender ji says my HbA1c is 14 for the last 10 years. That is not a good thing, but we'll bring it down. Don't worry. I'm 55 now. That is young. Maybe almost 55 on Dharmender bhai. And अब type 2 diabetes हो गया है. Can I start low dose of insulin? Yes, but I can't avoid sweets. So let's talk about sweets. And unfortunately, Dhawan Saab has hypersensitivity to metformin. So one drug is out. But we can take other drugs like sulfonylureas. But if HbA1c is 14, sulfonylurea will not act. It is a good idea to start insulin. We are not aware of your weight. Usually, doctors will start you on premixed insulin. That is twice a day. The premixed insulin will cover fasting glucose as well as post-meal glucose. However, if it doesn't come down, be prepared to take 4 doses of insulin for maybe 4 or 6 weeks. That will bring down the glucotoxicity. The HbA1c, which is 14, that is acting like a poison upon each and every cell of the body. Once we bring down that poison, all the cells of the body will begin working. And the body will get sensitized towards insulin, and then the insulin dose will come down. So your doctor may start 4 doses of insulin. Uh, Avoid sweets. So let us answer this question. You can take fruits. When you take fruits, try to cut them in such a way that you slice patle patle slices, thin slices, or dice, DICE. Dice means you cut it as a cube. You slice or dice them. When you slice or dice a fruit, you are increasing the surface area. And when you eat that fruit slowly, your taste buds get tickled, you feel happy. And the calories that are going in are not too much. Supposing you want to eat a date, आप खजूर खाना चाहते हैं, and let us say किसी ने रोजे रखे हैं and they want to break the fast with a date, they can take it. You tell them, make sure that you take a good quality date. Do not take the cheaper versions which are dipped in sugar. And when you take the date, you can always break it into 4 or 8 pieces and take each piece one by one. So you savor that single date. Don't push it into your mouth immediately. The taste is directly proportional to the surface area. That's one statement. Second is, supposing your doctor tells you that you take apple because apple has got low glycemic index. Don't take banana because banana has got high glycemic index. But banana costs 6 rupees and apple costs 200 rupees a kg. So you can take the banana, take half a banana and you make a raita out of it. Now I really do not know the English word for raita. Maybe Fatima can help us. पर अगर आप केले का रायता बनाते हैं या एप्पल का any fruit, what you're doing, you are cutting that fruit into small bits and pieces, putting it in in curd, in whipped curd, and you eat it slowly. So it gives you a very nice taste. You can add a little bit of salt, a little bit of other spices, and that gives you better taste. So you can take all the fruits and you can take it in a sliced or diced manner or as part of raita. Do not take a fruit cream. Avoid cream. Now, if all this is not enough, all our mithais, and it's not Dharmender Saab's fault because South Asian mithais, sweets are tasty. I mean, it's not our fault. So, all the sweets can be classified as boiled, uh, roasted, or fried. Avoid the fried mithais at all cost, but the boiled mithai that will include Bengali rasgulla and rasmalai, you can try that. Just make sure you squeeze it properly. You're basically eating the um, milk instead of drinking it. So you can take Bengali rasgulla or rasmalai after having squeezed it properly. These are boiled. Another way of classifying our mithais is, are they milk based like rasgulla and rasmalai? Are they lentil based like maybe chana barfi? Or are they um, cereal based like gulab jamun? Gulab jamun will be cereal based. Avoid the cereal based mithais. Prefer the milk based mithais. And if you want, every now and then you can take a lentil based mithai. At least some kind of protein will go in. If you take a chana barfi, do understand the difference in Hindi Urdu between chane ka atta and besan. Chane ka atta is flour made from gram. It contains fiber. Besan also comes from the black gram, but there is no fiber in it. The black gram is converted into yellow besan, and because there is no fiber, the glycemic index goes up markedly. So please avoid that at all costs. So here you can prefer milk-based items. Again, uh, right on top we have rasmalai and Bengali rasgulla. And by now everybody has understood what my favorite mithais are. Siddharth and Fatima laughing at my likes. And Fatima says raita is called raita, and Siddharth gives an English translation, sour milk. Though raita is not always sour, Siddharth, but sour curd hoti hai, and sour curd is very popular in Bangladesh and in West Bengal. That is another nice way of sort of taking protein. But you can take barfi. Now, barfi, you can make barfi in different ways. अच्छे से भुनी हुई बर्फी जो हो, which does not contain any extra khoya, you can take that and just put less sugar in it. If you're good friends with the guy who is making the sweets for you, you tell him to add a little bit of dalchini, which is cinnamon. That will give a tickling taste to the palate. And reduce sugar, avoid ghee, and include spices. One example would be dalchini. So these are all different ways of, and thank you, Dharmender ji, for raising this question. These are all different ways of sort of being happy while living with diabetes and eating very tasty things. This is what aristology is, or what culinary medicine is. And as a doctor, if you can understand these basics, you are actually able to help your patients live a much happier life with diabetes. Thank you, Dr. YP Singhal, sir, for your kind words as well. Diabetes Essential is there to sort of present diabetology in a very compact and simple manner. So today we've spoken about pancreatic diabetes. We've understood the difference between pancreatic and type 1 diabetes. In pancreatic diabetes, you have glucagon deficiency as well. So the risk of hypoglycemia is more. We also have uh, exocrine deficiency. So there is a greater risk of uh, malnutrition, diarrhea, steatorrhea. And pain is a very common feature in pancreatic diabetes. How do you manage? You manage with insulin, small frequent doses of preferably analog insulin. You can try ultra fast acting insulins if available. Stick to analogs because they are safer. You will also have to give pancreatic enzyme replacement therapy. Pancreatin is the drug of choice, and the indication is to reduce pain and reduce steatorrhea. It reduces pain by having a negative feedback upon the pancreas. Apart from that, you have to supplement the nutrients. So I forgot to mention that we have to supplement all the vitamins. That is important in pancreatic diabetes, and your patient will thank you for that. With this, I would like to thank you for having joined us today, and back to Team FDC.
Thank you very much, Dr. Sanjay Kalla sir, to take on the topic and answering the questions for all of us. And I would also thank all the doctors for joining us. Next week, that we will be coming up with a different topic. Till then, good night and Jai Hind. Thank you so much.
Yeah. Jai Hind.